Monkeypox is a zoonotic orthopox virus, incidentally, which causes diseases in humans. So, monkeypox is actually a virus which belongs to the pox group of viruses. In the pox group of viruses, we have various types of viruses, like we have orthopox viruses, we have parapox viruses, we have Yata pox virus, then we have mollusky pox virus. All of these different groups of pox virus family includes different viruses which cause different diseases. So now we'll be talking about monkeypox, which belongs to the orthopox virus group of family here. The lesions or the disease is very similar to the smallpox which was seen earlier, but now it's eradicated. And this monkeypox was initially endemic and is now also endemic to Western and Central Africa. We see that more number of cases are seen in Western and Central Africa than other parts of the world, but now it's been spreading. The number of cases are increasing and are coming outside of the Western and Central Africa as well. In the United States, we've seen cases being seen, and also in India, cases have been recognized. Monkeypox was first described or discovered 1959 when two outbreaks happened in a research laboratory. The monkeys were actually infected here, hence the name. It's called monkeypox because it's primarily a disease seen in the monkeys. The first human case, however, was identified in 1970, and that was seen in the Democratic Republic of Congo. And also many several cases after that we've been seeing. In 2003, we've seen cases. 2005, we've seen cases. In 2021, also we've seen cases arising. So the disease, as I told you, is endemic in Central Africa and East Africa. The natural reservoir of this virus is actually the wild rodents, the squirrels, primates, pigs, prairie dogs. These are the ones which actually hold or have the virus in them. Human to human spread can occur, but that is not very common. Etiology, as I told you, it's an orthopox virus and closely related to other viruses like vaccinia and smallpox. There are two types of the virus, something called as clades of the virus. We have the West African clade and we have the Congo clade. But here the Congo clade is said to be the more virulent clade of the virus. Now it is said that the number of cases that we are seeing now, the cases, these cases are because of a newer clade of viruses that is not yet identified. Transmission of the virus. As the reservoir is the wild rodents and the monkeys, the diseases actually start from them. Human to human spread can occur, but that is not very common, as mentioned before. Male having sex with male, the transmission among those population is seen, and the lesions in them would be again very localized to the perianal and perineal areas. Spread also can be seen from the respiratory droplets or through fomites or direct contact with the lesions as well. The virus is also secreted in the bodily fluids like urine, saliva, semen, feces, or even swab from the oropharynx has the virus. So the spread can occur even with the contact with these body fluids as well. Patients live in heavily forested areas wherein there is high amount of these rodents or monkeys present, or handling or preparing bushmeat, caregiving or taking care of someone who has got monkeypox or close contact with that particular patient can cause this. Vaccination against smallpox actually prevented monkeypox virus, but since smallpox was eradicated, vaccination against that was stopped, and hence after the stoppage of vaccination for the smallpox, cases of monkeypox have increased. And so not being vaccinated against smallpox also is a risk factor for getting monkeypox now. Coming to the pathophysiology of this, the virus will enter the body and replicate the site of inoculation, and then it will spread to the regional lymph nodes. And later there's a initial viremia which is seen, which later spreads to other organs as well. So all of this will happen in an incubation period of about 7 to 14 days is the incubation period, and on average it is around 21 days. So around 3 weeks is the incubation period during which all of this replication takes place. Clinical features, we see the onset is with nausea, vomiting, fever, breathlessness, lymphadenopathy, and cough. The patient will have all these vague symptoms. After 2 days, the fever will reduce and the rash will subside, and then the lesions will be the skin lesions that will appear. That is the papules, macules, which are erythematous, red-colored papules, macules can be seen on the white skin, and these are not very seen. They're barely visible on the dark skin. Number of lesions can be from 10 in number to around 1,000 in number they can be, and the sites affected would be the face, trunk, and the limbs, the commonly affected sites. Palms, holes, and mucous membranes also can be affected here. Cervical lymphadenopathy can be present here, so that's one of the important findings that we see here. And the lesions will evolve. The macules and papules will become pustules and blisters, and they become crusted. And once the crust falls off, the patient will become non-infectious. So until then, the patient has to be isolated. Condition actually actually resolves in 3 to 4 weeks. It's not a very serious condition if other organs are not involved. So the condition will eventually resolve in 3 to 4 weeks. So these are the monkeypox lesions that you can see on the patient, on the trunk, face, and on the limbs. You can see here. These are the papules and nodules that are seen. Here is a cervical lymphadenopathy shown in this picture. So again, on the face, you can see the maculopapular lesions here, mostly papular lesions with central crusting. Also, you can see some of the lesions have crusted as well. Pathology in the epidermis, there will be degenerative changes with cell fusion. With multinuclear giant, any of the viral infection will have multinuclear giant. So here also you have multinuclear giant cells and cytoplasmic inclusion bodies. Dermis will have inflammatory infiltrate. Electron microscopy will show us the typical pox virus. Pox viruses usually are brick-shaped viruses. So that virus can be identified in electron microscopy, can tell us the shape of the virus. There will be brick-shaped enveloped particles in the cytoplasm as well. The complications of the disease is it's normally a self-limiting disease which dissolves on its own. Sometimes it can lead to bacterial superinfection. There can be secondary bacterial infection of the skin lesions. The lesions can heal with permanent scarring, or they can heal with hypo or hyperpigmentation. Sometimes systemic involvement can be seen with death happening because of lung infections, pneumonia, sepsis, dehydration also can be seen. Encephalitis also can happen. Diagnosis is mostly clinical, taking the history of the patient, history of contact with another patient, or history of contact with an animal will tell us the diagnosis. PCR of the blister fluid can be done, and peptide-based ELISA also can be done. Treatment is, as any other viral infection, treatment will be supportive. Treatment is very important here, taking care of the symptoms that the patient has. Also, isolating the patient is important. Preventing the spread of the pox virus also is very important here. And lesions have to be covered until the crusts are formed. So after that, the patient will become non-infectious. Treatment options that we have here are 2 drugs which can be used here, which have been recently introduced for the treatment of monkeypox virus, and also has been approved for the treatment of monkeypox. So the drug is we have brincidofovir and we have tecovirimat. So brincidofovir is a DNA polymerase inhibitor. So this is the drug which is the DNA polymerase inhibitor which can be used. And also we have tecovirimat. Tecovirimat is supposedly a viral release inhibitor. So it's a viral intracellular viral release inhibitor. So these are the 2 drugs which have been approved. Dual therapy also has been trialed in a few cases. Tecovirimat actually will inhibit a particular viral protein, thereby it inhibits the viral maturation. Brincidofovir also was used in smallpox viruses before. Now it has been used here also. Along with brincidofovir, we give normal saline and probenecid for the patient. Also, we have seen that intravenous vaccine immunoglobulin also has helped in recovery of a few patients, which has been approved by FDA also, has been seen these days. And vaccination against smallpox, as I told you, gives some protection against monkeypox as well. Some progress has been made to develop a vaccine for monkeypox viruses, but that's still in the trial stages and not come into the market yet for use in the general population. We also there's another thing to remember. If supposedly there's an accidental exposure to the monkeypox virus, a vaccination can be taken post-exposure, and that has to be taken within 4 days ideally. But that has to be taken anywhere between 4 to 14 days.